I don't have any disclosures unless there are things I forget, and sometimes I forget and realize after the fact that maybe I should have disclosed something. But to my knowledge, I have no disclosures. Basically, introducing the scope of the problem is why we hear so much about opioid use disorder, why it's such a big deal, other than many people are dying from opioid overdose. But about 23% of people exposed to opioids will develop opioid use disorder. That risk of transition to addiction from exposure to a use disorder is second only to tobacco, coming in at 32%. So on the good side of this, majority of people who are exposed to these substances, such as cocaine, alcohol, cannabis, the tobacco or nicotine, and opioids, we're not talking about the majority of people developing a use disorder, but it is a significantly high number when you think about developing a use disorder when exposed, just simply exposed to the substance itself. So tobacco reigns king as always, but opioids are coming in a close second to that. Risk factors for opioid use disorder include genetic as well as psychosocial factors, and this does include history of sexual or physical abuse. When you think about our region in particular, where so I'm from here, so I can say this, where historically our gene pool has not been that deep necessarily. So a lot of sharing of genetics throughout families on the trunk and all the branches of that tree. And then our psychosocial factors where we deal with chronic poverty and poor access to healthcare creates a kind of a perfect storm, if you will, for us to see what we've seen in our region with opioid use disorder. Which I have a feeling you guys are more than aware of how important that is in our region. So out of a group of people 16 to 18 years old, they looked at the opioid prescriptions given to them, and they noted that there were lots of them prescribed for this age group, and that a lot of these individuals had pre-existing conditions that actually increase the likelihood of them developing an issue with an opioid use disorder. Things like psychiatric problems, anxiety, mood disorders, neurodevelopmental issues, sleep disorders, and then non-opioid substance use disorders. Those individuals were more likely than the counterparts in this study to be prescribed long-term opioids for things like pain. And long-term is more than 90 days. So when we already know that we've got some pre-existing conditions which probably were not assessed prior to starting and continuing opioid prescriptions, we've already started to prime the pump. And then if we take another step and look at the age group actually that was assessed in this study, 16 to 18-year-olds, that's kind of a really good age for initiation to use. This is a nice graph demonstrating for those people in 2011 who were able to access treatment services for an inpatient admission, the majority of them noted their initiation of substances, and this is any, not just opioids, but any substances, to be highest amongst those in the 15 to 17-year-old age group. So when we think about our adolescents and what our prescribing practices have been in the past, that also lends itself to the issues that we're seeing currently with opioid use disorder. All of that is to say what we're seeing in our statistics is really the tip of the iceberg. We know what we're seeing because of people accessing treatment. We know what we're seeing because of people who have opioid use related overdoses that are fatal. We do not have as good data on those who are not hitting treatment, those who are having overdoses and not dying from them, or those who are using substances in a dangerous way and not having overdoses, fatal or otherwise. So when we discuss the issue that we have in our region and nationally with opioids, it really is the tip of the iceberg. And it's important that we are assessing risk factors for our patients as well as current habits for our patients. This is kind of an advertisement calling to arms, and it's kind of kudos for my specialty in family medicine. Opioid use disorder is disproportionately impacting rural areas, and those physicians in rural areas who are able to prescribe buprenorphine tend to be family physicians. We're the most likely to work in rural areas. So the places that we need physicians the most, rural areas, most often you're going to find family physicians there. we are primed to be the ones who are providing this care. So basically what I'm getting at, since I'm talking to a group of psychiatrists, is you guys need to look for jobs in rural areas. Please go and work in these areas because they need you. They need you desperately. So when looking for work, especially all of you who are in your last year of residency, please think about going to rural areas. So available treatments for opioid use disorder, because that is kind of, you know, the highlight of this story, is that we do have treatment, and we have good treatment for opioid use disorder, unlike stimulant use disorder. But that's not today's talk. We're talking about the good stuff that we have for opioid use disorder: pharmacotherapy and behavioral therapies. Those are the two things we have. Gold standard is both, not one in isolation without the other. That can be helpful. It's better than nothing, but if you can go with both, combining some type of pharmacologic along with counseling or some type of behavioral therapy, that is our gold standard. That is the goal. That is what we're reaching for in order to affect change in individuals' lives so they can move into recovery and have a history of opioid use disorder and not a current active opioid use disorder. So when we think about abstinence alone, because that is definitely a way to go about managing opioid use disorder, what we see is people returning to use. Not everyone. There is definitely a percentage of people who do not return to use. Unfortunately, though, they are in the minority. Those who receive MAT, however, will maintain abstinence longer than those without. So slightly confusing graph, sorry, I was looking at it last night and I'm like, it makes for a picture, so we'll just leave it there. But basically the words are really where the impact of this slide is. About 50% of individuals who were part of this prescription opioid addiction treatment study, POTS, I guess, received 12 weeks of buprenorphine naloxone combo, and they were abstinent at the end of that 12-week treatment period, and then they tapered them off. And when they tapered them off, the abstinence rate rapidly collapsed to less than 10%. So we were almost 50% while on treatment, and then we dropped to less than 10% when the medication was gone, about 2 months following fully being tapered off the medications. When they went back and looked at this group of individuals who had participated in the study, the 18-month follow-up period found that many of those individuals had maintained on buprenorphine, even though maybe they'd been tapered off, they quickly went back to it, or had recently re-engaged in opioid agonist therapy. There's so many ways to talk about the medications that we use when treating opioid use disorder. Methadone and buprenorphine will be referred to as medication-assisted treatment, medication-assisted therapy. There's opioid replacement therapy is one, opioid agonist therapy is another. It's just a bunch of words to say we're using a pharmacologic to help treat their condition. But when people re-engaged in pharmacologically supported treatment, the abstinence rate rebounded and got back to that 50% mark. So being on a pharmacologic did seem to make a difference in this study. So when we treat patients, our goal is to do good for them. And from the studies, and there's so many of them out there, that demonstrate being on a pharmacologic, such as methadone or buprenorphine, provides an opportunity for abstinence from illicit opiates and other substances. You guys probably come across this phenomenon as well. We may have someone on buprenorphine who's no longer using illicit opioids, but they are continuing to use other illicit substances. However, if we have someone on a good stable dose, they're engaged in counseling, we start to see those other substances subside, their use going from frequent to infrequent to abstaining. Harm reduction in relationships, employment, and legal consequences. So when we have our patients stabilized on medication, we see relationships improve. Either they start engaging in better communication or they start trimming some of the relationships that are not positive and supportive for their recovery. We see them being able to go and interview for jobs, gain employment, keep employment. They're able to meet any of their probation requirements, get off of probation, pay their fines, and move away from the legal system. You also will note decreased health needs, meaning decreased utilization of ERs and admissions, because hopefully they've also connected to primary care services, which the model for our clinic that we have for the Addiction Medicine Fellowship, it is housed in a primary care office, meaning that when those health needs arise and they become more than we can manage in the Addiction Medicine Clinic, we have primary care providers right there to transition our patients to. overall better sense of quality of life. One of the things we do in our clinic actually is do a quality of life assessment. There's a World Health Organization quality of life assessment. It's 20, 30 some questions that we'll go through to get a sense of like, how do you feel you're doing in life, and identifying areas for improvement that they would like to feel better about. What that looks like when they first come into care versus 6 months, 12 months after they've been in our care. It's nice to see that transition to an increased sense of quality in their lives. Buprenorphine itself provides a lot more flexibility and safety than some of our other choices. That's code for methadone. Other MATs like methadone, flexibility and safety is one of the downsides of methadone, just because of the way we have to manage that. So that flexibility is nice using the buprenorphine in our clinics. Utilizing buprenorphine in the emergency department is something we don't do enough of, especially here, because we don't do it. So we should do more of it. Some places are doing this, where they're engaging patients who present to the emergency department either in an overdose, withdrawing, or have come in with conditions secondary to their substance use, and engaging them in care right then and there in the ER. This website that I have listed at the top with that hyperlink, and I think you guys will have access to the slides when we're done with today's presentation. You just go and check it out. There's loads of really interesting information from the American College of Emergency Physicians. So an X waiver is needed if you're writing a prescription for somebody to take and go to a pharmacy and fill. If you're in the hospital, you don't need an X waiver to write for the medication to be provided in-house. So if you are in the ED seeing a patient, you treated them for their abscess, or they were treated for an abscess in the ED and were written for a dose of buprenorphine, they can come back the next day and get another. They can get it again. They can do it for 3 days, basically, that 3-day rule that's written there in the middle. You can also, if someone is admitted to the hospital, so if you've been consulted on a patient for a psychiatry consult, and you're recognizing part of their issue is they might be in there withdrawing because they aren't getting what they normally use on the street, and because the urine drug screen that we do when we admit patients from our ER, it's kind of a joke of a urine drug screen, sorry. There are substances that may not show on there that our patients are using, and you've been called for a psych consult and really your patient's in withdrawal. You can write for them to start buprenorphine without an X waiver in the hospital. It's on the formulary, and you don't need an X waiver for inpatient care. However, when you're discharging that patient, you do need someone with an X waiver to prescribe it, for them to fill it in an outside pharmacy and not through the hospital pharmacy for inpatient management. So you can get it started, but that X waiver is needed for continuation out of the hospital. So I alluded to this a moment ago, where if you are abstaining only from your substance, your likelihood of return to use is much greater. Retention and treatment and decreased use of illicit opioids on MAT is much greater than if we are not engaging in the use of a pharmacologic to help manage the opioid use disorder. Buprenorphine itself in studies has demonstrated promoting retention, and people who remain in treatment are more likely to abstain from other opioids over time. So getting them in and keeping them in. Some of the ideas regionally, and in particular with TennCare, that they need to be on it for a minute and then you can get them off is appropriate care, is inappropriate. We're working on that. But benefits of MAT also include decreased mortality. As you can see, general population, just general risk of mortality, very low there in the green bar. And then medication-assisted treatment definitely gets us much closer to the general population as far as risk of just general mortality as compared to no treatment, that very tall, long red bar. So it's not just good for our patients, it's also good for us. Because when we see patients, it's really nice to see your patients get better. You know, there is some satisfaction, I guess, in the world of family medicine when you started someone on a blood pressure medicine and they were, 210 over 180, and then after a few months of being on your antihypertensive medication you wrote for them, they're coming in at 120 over 80. Like, those numbers are pretty and that's great. And your patient is like, meh, I don't know, I take this stuff. It makes me pee a lot. They aren't really saying thank you for that all the time. Sometimes they do, sometimes they don't. But I'm telling you, the patients that tell us thank you who are coming in and getting treated for their opioid use disorder, it's the change is quite fun to engage in, watch, and participate with them. And so you see that short-term, quick turnaround, someone coming in who's talking about how they feel normal, how they're able to engage in their life in a much more positive sense. And then 6-12 months after working with them, seeing all the ways that they're starting to grow and engage with the world around them in really rewarding ways. So short-term and long-term. So we don't have to totally wait for that delayed sense of gratification, which we were told since medical school we needed to get used to, because our patients do get better and they keep getting better. When you find yourself in a situation where the patient is constantly, I need more opioids, I need more opioids, I need more opioids, I think I need to assess you for an opioid use disorder. What's going on in your life? Like, I actually have an answer for when I've identified someone who has a use disorder. I have an option for them. Their choice of whether they're ready to engage with that or not, but I know I have an option. So that leaves me feeling much less manipulated or helpless, like I've been painted into a corner and my only option is to just piss off yet another patient. I do have an option to offer them. When we improve someone's blood pressure, we decrease their stroke risk, we decrease their cardiovascular risks, we put people on medication that helps them function better in the world. That's nice to see. But when we also are able to provide people a means to a better life, a stable life, through providing them treatment for their opioid use disorder, we're also having a very large impact on our society, which I think is my next couple of slides, where we're able to get people to jobs. They're paying taxes, because we all love to pay taxes, but that means that we've got more people chipping in to repair the potholes on our streets because they've got jobs that provide them with benefits. They're able to get health care that they need. We're making a difference on an individual level, but also on a society level that we don't always get with all the things that we do in the treatment that we provide. So good for community. There's a lot of statistics, words here. I love words on a slide. Kidding, I don't. I like pictures. Basically, I'm going to focus on the top and the bottom here. And this is an older set of numbers, but I don't think things have changed drastically in a more positive light. If anything, they probably lean more higher percentages that I'm about to tell you. But these do come out of the Bureau of Justice Statistics. 2007 to 2009, about 58% of state prisoners and 63% of inmates in jails. So two different systems there between prison and jail. And you can tell it's old because we're talking about DSM-4 and not 5. Met criteria for drug dependence or abuse. So that's the language from DSM-4, which is not the language we use now. But over 50% of the individuals in those systems met criteria. And of those who met criteria, roughly around 25% of them had participated in any type of drug treatment program since being admitted into the justice system. So way more than half meet criteria, yet only about a quarter are able to engage in treatment programs. So they're just demonstrating that crevice, that canyon between knowing what we have and being able to connect people to care that will make a difference. And I think the rest of the words in between those 2 points that I made just basically points out that a lot of the individuals who are justice involved are also dealing with substance use disorder, and that drives a lot of the recidivism, return to judicial system, and the inability to get out of the judicial system. So by engaging people in treatment, it leads to reduced crime. It gets people out of that revolving door. Different formulations of buprenorphine that are available. We've got buprenorphine plus naloxone, and the brand names for that include Subzolve, Suboxone, Bunavail. Those come as tablets, which is the third picture over, the funny looking hexagon, orange hexagon, or films. I personally like using the films because I can manipulate those a lot easier than some crumbly tablets that are strangely shaped. And then there's Subutex, which is the mono product, little white pills typically. Mono product, meaning it doesn't have the naloxone or abuse deterrent in that formulation. And then the injectable form. There is a rod that you can implant. I didn't really put that in here on this slide. It shows up in a later slide. But these are the two that are, but I can't say that second one, so I'm not going to try. But the two depot preparations of buprenorphine basically are injected subcutaneously, form a gel, and you do repeat injections periodically. Sublocade is about every 4 weeks that you're providing that one. Oh, yay, pharmacokinetics and pharmacologics of our medication. It's actually a pretty exciting medication, the way that it works in the body. Buprenorphine is a partial mu-opioid receptor agonist, meaning it does not fully activate the mu-opioid receptor compared to methadone, morphine, oxycodone, Dilaudid, all those other guys. Those are all full mu-opioid receptor agonists. It is also a weak kappa opioid receptor antagonist. And you guys probably know all of these things much better than I do. But kappa opioid receptors, when agonized by our full opioids, it's a depressing effect on that receptor. So it has a depressant activity, which is why we think of our opioids as downers or depressing type medications. They can provide substance-induced depression symptoms. So buprenorphine does the opposite. It's an antagonist at that receptor, which is actually kind of an important, people forget often, point about buprenorphine. In clinically used doses, buprenorphine will act like a typical mu-opioid receptor agonist, like morphine or methadone, meaning that when it sits on the receptor, it activates the receptor, but it doesn't fully, that's why the partial bit, activate that receptor. So we end up not having some of the dangerous effects of those full opioid agonist receptors. We hit a plateau with what the buprenorphine is able to do at that mu-opioid receptor. And then at even higher doses, so FDA approves up to 32 milligrams of buprenorphine a day. TennCare doesn't agree with the FDA on what we can prescribe for patients and what they'll pay for, but it may be that as we do get to some of those higher doses, we are actually starting to have an antidepressant effect because of that antagonism at the kappa opioid receptor. The ceiling effect of buprenorphine does reduce its abuse potential and risk for overdose, even if someone takes it intravenously. When I've done inductions sometimes with people, because I do home inductions, and where I used to live in New Mexico, I would often, usually all the time, have to write for extended periods of buprenorphine because people couldn't do a 6-hour round trip back and forth to my office 2 days in a row to do the induction over 2 days. So I'd write them for a week because they could do that. I would have people come back who had taken 48 milligrams in a day. And I'm like, you ran out, and it didn't make any difference whether you took 32 or 48, or it just, so one of the nice things about buprenorphine is if people do take more than you intend for them to use, we hit that ceiling and their risk of overdose isn't there. The risk of respiratory depression isn't there like we would see it with our full agonists, and in particular methadone, which is why we do not send people home on methadone to have daily take-home doses when they first start treatment, because that will kill you. It does have a slow dissociation from those opioid receptors. And what that does is it kind of keeps the opioid receptors occupied for extended periods of time. The half-life is very long with buprenorphine. So you can actually dose it so that someone's taking it every other day. That's actually a scheme for when you are weaning someone off. You increase the dosing interval to every other day, to every 2 days, to every 3 days, while you're also reducing your dose. So it's kind of a fun medication to play around with just because of how the pharmacokinetics work in our, they work on all those lovely receptors. So again, hitting home that partial agonist quality of your buprenorphine. It binds to those receptors so that we prevent withdrawal symptoms, and that steady state of opioids that are present help reduce cravings, but it also acts as a blockade, which is an interesting subject to discuss with your patients, because they all think when you have them on the combo product that it's the naloxone that's blocking the effect of any other opioids they might take while taking the buprenorphine. It's actually the buprenorphine that acts as the blockade, not the naloxone. Naloxone half-life is very short, and it's there they are meant to be an abuse deterrent. So it's really not doing the blockade. It's the buprenorphine that does the blockade. It sits there, it occupies the receptors, it binds very strongly to the receptors, so nothing else is really going to push it off. You give someone an intranasal squirt of naloxone, you can push them off with the naloxone, but when you put that strip or tablet under your tongue, very little of the naloxone is absorbed, and whatever is absorbed, its half-life is so short, its impact is negligible on what's happening with what does get absorbed with the buprenorphine under the tongue. So peak levels after that sublingual administration will hit the body about 30 to 60 minutes after that administration. Half-life is about a day and a half. So you've got about 30, you read different numbers, but 37 is kind of in the middle of the half-life of what you'll read about buprenorphine. It can precipitate withdrawal if you start it too quickly when someone has been using full mu-opioid receptor agonist medication. So if someone crushed up and snorted some OxyContin that morning and they start the buprenorphine you wrote for them at noon, it's very likely you'll precipitate a withdrawal because those opioid receptors are full of the full acting opioid, and then your partial opioid with very strong binding will come and shove the other opioid out of place. And so when you shove all those other guys out, people go into withdrawal. And because of that, you can have some difficulty getting people initiated on buprenorphine. So timing is important. However, when you do start someone on buprenorphine and you do precipitate a withdrawal, if you just keep on providing them with buprenorphine, you'll eventually get enough buprenorphine on the receptors that you stop the withdrawal process. There are many different ways to do an induction, and I'm not talking about how to do an induction today, so I won't go through all those ways, but just as a way to think about it, starting off, you can do 2 to 4 milligrams of buprenorphine, and then you can continue over that first 24 hours to add in more doses of buprenorphine. I usually have my patients max out at 16. Do not take more than 16 in the first 24 hours. And then next 24 hours, we start at the total dose they took on that first day. There are lovely printouts you can give to your patients. There's so many different ways to do this. Just trying it on, seeing how it goes, making adjustments, asking those like Dr. Hayel, who I see who's also on this call today, and myself, how to do this. We'll have so many different ways for you to do it. You'll be confused which one to start with. So we'll just tell you, start them on 4, tell them to go up as they have withdrawal symptoms, and then repeat on the second day. You can do it in-house, so in your clinic, or you can do it at home. Both ways are safe. When someone takes buprenorphine and they place it under their tongue, they're actually only getting about 30% of that medication absorbed under their tongue. If your patients are swallowing their buprenorphine, they're getting less than 5%. So knowing what they're doing with your buprenorphine is important, especially if you're having a hard time getting someone stabilized on a dose. And it will surprise me sometimes when I feel like we've talked about it, yet somehow they're like, well, I just sort of suck on it while I've got it under my tongue. That will not work. They're swallowing the medication and they're not getting all of it under their tongue. So it's entering directly into the bloodstream by absorbing through the mucosal surface under the tongue. Whereas when it goes through their stomach, it's getting processed in all kinds of ways that mean they are not getting the medication. If they inject it, they get 100%. So knowing how your patients are using the medication is important. Naloxone is there meant to be an abuse deterrent. People will inject it. I'm really ready for us just to have a single formulation. I don't care which one, quite honestly. I just want one. I think it would make everybody's job and the worry that we who prescribe buprenorphine are encouraged to have about what our patients do with the medication we give them. It would help us not have that worry. Just take your medication as I prescribe it. If you're not, we'll figure it out, figure out how to get you on track to using it the way that we need to. I've talked about this a little bit. It's summarized much more nicely on this slide. High affinity for and slow dissociation from the mu receptor prevents those withdrawal symptoms, decreases your cravings, and decreases the effects of other opioids. However, this dissociation curve off of the receptors means that there are some receptors available at any given time. So a full agonist opioid can slip in there and bind and fully activate that receptor, which means that people can override their buprenorphine and use an illicit substance in hopes of achieving a euphoric effect, which is dangerous because that increases the likelihood of overdose. However, it is beneficial when we are trying to take care of a person who has an acute pain event, such as they've broken a leg or they've had an emergency surgery. If we need to use a full agonist opioid, we can use a full agonist opioid. We will just likely have to use higher doses to achieve analgesic effect by using those full agonists. We can also use the buprenorphine itself by dividing the dose up throughout the day to get the analgesic effect of buprenorphine, because though it is only a partial agonist at the mu receptor, it is still an opioid and it has analgesic properties. So if we divide it up, we can utilize those properties to help our patients who are having an acute pain event. If you are using a full agonist opioid on a patient who is using buprenorphine, higher level of observation of your patient is recommended. So you may have a patient who's on the med-surg floor that because they've had abdominal surgery and they're now getting morphine as a PCA, or they're getting PRN morphine in an IV. You may want to put them on, what is that unit? The PCU. It's kind of like that in between med-surg and ICU. And sometimes even putting your patients in the ICU so they have a little more one-on-one following from nursing staff to make certain that we don't get into trouble with higher doses of full agonist opioids. When you have patients who have acute pain events, not treating their pain is not okay. If they have an opioid use disorder and if they're on buprenorphine, they still need to have their pain addressed just like anybody else. Buprenorphine is not a reason to not treat your patient's pain. You can use the buprenorphine to address their pain, but sometimes you need a little bit more. So just keeping that in mind. Some of the side effects of buprenorphine include dry mouth, nausea, vomiting, constipation, dizziness, sedation, headache. That's basically the side effects you get with every single medicine we give our patients. I have definitely run across excessive sweating and headache. Headache seems to go away over time. I've also noted using different formulations of buprenorphine can make a difference. I have one patient that if she gets the generic from Sun Pharmaceuticals, it will give her a headache. So her prescription says, any generic is okay, just not those from Sun Pharma. As long as we stay away from those, she does fine on her combination product. Many people use these side effects as a reason to get on the mono product, which is part of why I just want one. And again, I don't care which one. Flip-flopping from mono product to combo product and back and forth, especially when struggling with pharmacies and insurance coverage. Just it provides stress that none of us needs, patients or providers. Constipation is a side effect of opioids. So there you go. And we have ways to combat that. One of the nice things about buprenorphine, and also why it is a safer choice than methadone, especially if some of your patients have either underlying heart conditions or medications that prolong a QT interval, you don't have that issue with buprenorphine like you would with methadone. And again, partial agonist compared to full agonist, buprenorphine has a lower overdose risk than methadone. So this is a nice table. It's a little fuzzy, summarizing the different formulations. I had a patient with significant nausea on the tablets. We switched her to film. The nausea went away. So I think oftentimes the side effects and issues people have with the medication isn't our active ingredients, it's the inactive ingredients, to be honest with you. And I think that goes for many of the medications that we use. Who knows what those inactive ingredients are? We don't have to list them. So sublingual and buccal formulations, strips, tablets, the dosing between, so like Univail, Subzolve, and Suboxone, just to go with our brand names, it's different and they are not equivalent. So 5.7 is not the same as 4 milligrams of buprenorphine between Suboxone and Subzolve. So you do have to look at those conversion factors to make certain that you're giving your patient an appropriate dose and you're not underdosing them, because that's what I most often see when people are switching from something like Suboxone to Subzol. The mono product, it's nice that we have that available as an implant or injection. I mentioned the implant before, it really didn't take off that great. And considering it's 4 implants that are good for 6 months is probably a large reason why it's not taken off all that well. I think Sublocade is starting to gain some ground. I have not yet had the opportunity to use it in my clinic, but I am always looking for the opportunity. Advantages of buprenorphine to treat opioid use disorder. Patients can participate fully in treatment activities, other activities of daily living to help ease their transition into the treatment environment, largely because we can do it in an office-based setting. So they can get many things taken care of at a single visit, including their opioid use disorder treatment. Hours are more flexible for them, so they can engage in other activities of their life without having to report daily for dosing. Limited potential for overdose, I've already reviewed multiple times now. Minimal subjective effects like sedation. We really don't see the sedation like you do with a full agonist on those mu receptors. Enhancing retention and treatment, reducing relapse rates, preventing withdrawal, blocking the euphoric effects of opioids. As I mentioned, available for just regular office settings. You don't have to be a federally designated center in order to be able to provide buprenorphine. The naloxone does discourage IV use, sort of. I have patients who will inject, they aren't currently, we worked on it, we're doing well, IV use of the combo or the mono product. And then take-home dosing. I've got patients right now who are on 28 days worth of medication. If we hit some bumps in the road and we need to decrease our dosing interval, then we do. But we can have extended periods of not having to return to the office. Disadvantages, it can cost more. Thank God for GoodRx, because that makes it a lot more affordable for a number of my patients. Patients, because it is an opioid, they do remain physically dependent. For those patients who are adamant about not being physically dependent on a substance, but they do want something to help reduce their return to use, something like naltrexone, Vivitrol, the injectable formulation, is a good choice for them. Detectable on specific urine toxicology screenings. So that's kind of back and forth. Like, you have to have a specific one. You can't use that wonderful SAMHSA 5 drug panel that we have in the, to be specific about the urine drug screen you're using, because you will not pick it up on a urine drug screen that screens for opioids. Opiates, because you're only going to get morphine and codeine and heroin on that one. But if you're looking for oxy, that will get you oxycodone, but it will not, any of those show you buprenorphine. So you've got to do a specific drug screen for that, and that can contribute to cost. There is also the potential for diversion, because often we are doing days, weeks at a time of the buprenorphine. Sorry, something weird was happening on my computer, but I hope everything's okay. So just like the title slide said, buprenorphine is a slice of this pie, and as mentioned on a couple of other slides, combining things such as behavioral supportive therapies and medication, that's the gold standard. So buprenorphine plus engaging our patients in parenting classes, counseling for co-occurring diagnoses or substance use specific, family, couples, getting them job training, skills development, connecting them to services to help them get their GED, signing them up for job fairs, helping them with transportation, getting them secure housing, access to food. All of these things make a huge difference. A prescription alone will not provide that structure. Helping connect people to resources to increase that structure, really, that's the whole pie. And when it comes to pie, I don't want a slice, I want the whole thing. So buprenorphine is a good component to that pie, but we need all the other elements to help support our patients if we really want to see change take effect, take hold, and for them to move forward on the road to recovery. And that is the end of my presentation. Thank you, guys. Questions, because we have a moment.
Well, thank you so much, Dr. Troxler, for this excellent presentation. We really appreciate the information about buprenorphine and let's open it up to questions. I don't think anybody has used the chat feature, so if we want to just take turns, you can unmute yourself and just ask some questions.
Hi, Dr. Troxler. I have a question. How much do we know about the kappa opioid receptor antagonist effect on antidepressant as a to be used as antidepressant?
We do know that it has antidepressant qualities when you antagonize that receptor. So if you aren't allowing it to be activated, it can have antidepressant effects. I don't feel that there's been much study and look at that. The idea of us using an opioid to treat depression, I don't think it's ever going to happen. So I don't know how much emphasis there is on looking at that as a potential modality of treatment for anything, to be perfectly honest. I just think it's a nice aspect of the buprenorphine that I don't feel that many take into account when thinking about dose of buprenorphine. And the reason why I bring it up is kind of a bit of a soapbox for me. It is a struggle with insurance companies and what they will cover and allow us to provide our patients, because cost is a barrier. If you can't afford it, you're not going to get it. But if I have a patient who's doing okay on 16, who might do better on 24, but they can't afford it, then I can't get them there. And it may not even be because of the mu opioid receptor effects. It may be something happening with the kappa that I don't even know, because I don't have studies to back it up. We all know that it has that capability. But again, I don't know that anybody's really looking into it to explore that as a real viable option for antidepressant effects.
Thank you.
Thank you, Joyce. I think that the one thing I would like for you to also emphasize on that is the pharmacokinetic about the accumulation of the naltrexone and the buprenorphine in people with the liver impairment.
So we actually had this come up in clinic recently because there is so much controversy, more here than I've experienced elsewhere, around mono product and combo product. So buprenorphine alone or buprenorphine plus naloxone. I can't tell you, I have tons of people who have an allergy to naloxone, which is a little frightening if you have an overdose, which they would get naloxone anyway. But the issues that many people cite, they'll get hives, they'll have itchiness, they'll have nausea, they'll have headache. That's usually what's reported with the naloxone being present. But we did have a patient who had liver dysfunction secondary to alcohol use disorder. He also has chronic pain, and even though he doesn't want to admit it, he has an opioid use disorder. So we were utilizing combo, the buprenorphine naloxone product for him, and he has, because of his alcohol use disorder, chronic pancreatitis, which causes him a lot of nausea and a lot of vomiting. So as we started increasing his buprenorphine naloxone dose to get better control of some of the chronic pain he also has because of the chronic pancreatitis and many injuries that he's had, his nausea and vomiting actually began to worsen. So when we were looking it up, naloxone, the way it's cleared, does involve liver. And those who have liver dysfunction may not clear it as readily. So you can actually have accumulation of naloxone. It has a short half-life, right? So it goes in, you process it, it's gone. It's like 30 minutes half-life. But in someone who has liver dysfunction, it may be hanging out longer. And for this gentleman, we were concerned because we were using it for pain. So we were dividing it. So he was taking his buprenorphine naloxone 4 times a day. So we were putting naloxone in his system multiple times a day. If he wasn't clearing it as readily, then maybe our treatment was proving to be a detriment. So we ended up flipping him over to mono product. I think that was successful for other reasons, not our medication change. He's not had good success in our program. But the nausea vomiting did start to get a little bit better when we made that change. So it is something to think about and keep in mind, which is why getting labs, even though buprenorphine, there is some literature that says, following people's liver function on buprenorphine is important. It actually hasn't been shown to have an impact on liver function itself. Only in the setting of someone who has acute hepatitis C do we see addition of buprenorphine really impacting the liver in a negative way. But it is nice to have those baseline liver enzymes when you start someone on buprenorphine, or you're monitoring them while you have them on buprenorphine, because oftentimes we're seeing not just an isolated substance use disorder such as opioid use disorder, we're seeing other stuff. And as this patient is an example, significant alcohol use disorder, which definitely was having impact on his liver.
I see that Carrie Roby had submitted a question in the chat feature. She says, thanks for this informative overview. I wondered, you'd mentioned the gold standard treatment is comprehensive model of MAT plus therapy. Are there any studies that you're aware of that show a dose-dependent relationship with therapy, such as the duration or number of sessions, like the 12 to 16 CBT sessions versus ongoing therapy for the duration of MAT?
No. I understand the question, and it's a very short answer, because there are actually some studies that show that people do as well with counseling as they do without counseling and just MAT. We were talking about it in clinic the other day, though, and it's like, who are these people that they studied, and who do we know who has just simple opioid use disorder? The likelihood of there being concomitant conditions, PTSD, anxiety, depression, bipolar, a bunch of other things, or multiple substances that are issue or concern, the trauma, unprocessed. How long did we look at these individuals and see, like, they did great for 2 weeks of our study, end of study. Like, so I'm not aware of any that are looking at, like, if you do this and you do that and you do it for this long, you have a better outcome than if you did that or you did this. It's one of the fun things actually about the work that we do. The same thing isn't going to work for every single patient. Someone 12-step may be their jam. It may be perfect. It will do wonders for them. And for other people, they're like, yeah, I went to those meetings and I just hooked up with people and used. That does not work for me. So we need to find other means of engaging in counseling. Some of them, they need EMDR. They've got trauma that is not processed, and nothing's going to make a difference until we process that trauma. But we also have to get them stable enough with their treatment. We're not continuing to use substances. We're engaged in some just daily living, surviving strategies through some of our other counseling interventions, just connecting people to housing, and they've got a roof over their head and a key to unlock the door, before we can engage in some of those other modalities to treat underlying issues like trauma.
Joyce, this is Jack Woodside.
Hi.
You comment on the overdose risk of combining benzodiazepines with buprenorphine?
So there was, I think it was 2016, it popped up, black box warning, buprenorphine and benzos, like, we need to not do that ever. Don't do it. You must stop it immediately. Or we're going to take you to Dr. Jail. I'm kidding about that. They didn't say that on the black box, but it was very strong wording that we needed to not do that. Concomitant use was basically like contraindicated. Don't do it. Don't do it. And if you're doing it, we're going to think really bad things about you. And they've revised that. It may have been 2019 that the revision came up. Be cautious. Try not to do it. We understand sometimes it has to happen. Because when they looked between when they came out with the wording in 2016 for that black box warning, most of the danger of concomitant use is when benzos were being used IV. I think we all know, unless you're in a hospital on a benzo drip for your alcohol withdrawal, you should not be using it IV at home. So this would be unsupervised use of benzodiazepines IV, and that increases the risk of overdose. Ideally, we are working to get our patients on appropriate treatment regimens that do not include benzodiazepines. Sometimes that's what they're on. Sometimes they've been taking benzos since they were 11 and they're now 50. Our success of getting them completely and totally forever off of benzos, that's a challenge. We can do the best we can. We can pick safer choices, like how about never ever Xanax, but maybe Valium. So it's harm reduction and risk mitigation, I think, when it comes to benzos. Having those conversations with your patients about what the risk is, because a lot of them don't realize there is a risk there. And again, assessing what else might you be using, because if they are also drinking alcohol and we are not talking to them about that, just the benzos and alcohol alone are a risk. But then you put multiple substances in anybody's system and your risk of overdose goes up. So counseling our patients and having frequent check-ins with, what are you doing now? How about today? What about last week? So that we know the risk that they're facing and we provide them with appropriate education and direction on better therapeutic regimens for them.
Thank you for the lecture. I had a quick question, Dr. Troxler, regarding like endpoints, and this kind of comes from anecdotally hearing that withdrawal from buprenorphine can be quite difficult. So I'm kind of curious, is it an indefinite treatment, or is there a goal at some point, or it's kind of a case by case? Just curious from your experience.
You gave me my answer, Dr. Glass, case by case. It really depends on the individual and where we're able to get them in their recovery. It's not a one size fits all regimen. Some people, especially like we've got a couple of people in clinic right now where their opioid use, when they were using and when they started treatment, they've been in treatment longer than they used. They seem to be on a very successful path for weaning off. When working with individuals who have maybe been using opioids since their teens and they're in their late 60s, I'm not certain that we'll be weaning them off successfully at any point in time. So it depends on the individual, what they're able to do. And again, not one size fits all. So can we wean people off? Yes. Should we wean everybody off? It'd be great if we give everybody the structure they need and the positive, community that they need and the support that they need, and the brain heals the way that it needs and we can move away from it. But those are all very independent individual factors as to what we can and can't do. Just like sometimes we get people with diabetes and it's like, this is not going to be my life. I'm not going to go down this road. I'm now exercising and I'm not eating pizza every other day and I've lost 50 pounds and I never had to start a medication, or I was on it briefly. And they're able to maintain that lifestyle and they don't have to go back on medications, but genetics may catch up to them and they end up on medication, even though they're doing everything appropriate in their lifestyle. So between lifestyle, life experiences, and genetics, all those factors come into play as well, which again is why one size does not fit all for individuals who are on treatment for a substance use disorder. I saw another one pop up in chat, opioid use disorder in pregnancy or postpartum, management and postpartum. So this is another fun topic for our region. Having done, cut my teeth on substance use disorder treatment in New Mexico, where it's a very different mindset and philosophy, as some people will refer to it, than what I've encountered here. ACOG tells us, and that's the American College of Obstetrics and Gynecology, tells us that best course of treatment is to have women who are pregnant on maintenance medications, to not wean them off during pregnancy. If you have a woman who is actively using full agonist opioids, get them on maintenance treatment. So if you've got a woman who is using heroin or snorting oxycodone, get her on maintenance treatment. Our region has a lot of people who are already on buprenorphine. I have not had to do very many inductions since I've been here because people are getting it off of the street. So a lot of times a woman will show up pregnant or be in a treatment center and become pregnant and she's on buprenorphine. And ACOG and a number of other studies tell us we should not wean these women off of medication. That's a should or should you not? Can you? You can. It is possible to wean a woman while she's pregnant. That I don't think is the appropriate question. I think the appropriate question is, should you wean a pregnant woman? Pregnancy is a very vulnerable time in general. When you're pregnant, you're more at risk for things like intimate partner violence and other traumas. So taking away stability while pregnant and in that vulnerable state does not seem like a safe and patient-centered practice. However, if you've got a woman who has a wonderful supportive partner, she has good family support, she's got transportation, she's got financial stability, she has housing and food stability. And she's been on this stuff forever and no one will wean her off. And she's like, I've had it, I want to come off. You're like, well, let's talk about what that's going to look like. We can do that. But there are some important questions and things you need to know about an individual before you engage in weaning anyone, much less a pregnant woman. Postpartum, this is fun. So there are studies that are starting to percolate up between whether you should be on mono product while pregnant or combo product. I think the idea is if you're injecting your combo product, you're at risk for precipitous withdrawal with the naloxone piece, which isn't so hot for baby. Not hot for you, not hot for baby. But truthfully, most people are taking their Suboxone appropriately. So you can be on Suboxone during pregnancy. More and more studies are showing us that's okay. But we tend to switch people onto mono product during their pregnancy. My practice in New Mexico, because I did the delivery as well. So I managed their buprenorphine, I delivered their babies, I took care of their babies, I took care of them postpartum. So I was in control of the whole spectrum, which was nice for someone who likes to be in control. So as soon as the baby delivered, I basically would switch them over to Suboxone because they weren't pregnant anymore. There's no need for it. So we'd switch it over. Naloxone is not getting into the breast milk. Neither is the buprenorphine. It's a very large molecule and it does not transmit into the breast milk. So when we go from umbilical cord where we're getting all of that to breast milk and getting pretty much none of that, Suboxone is totally fine. And I just saw a comment pop up. People prefer the Subutex to the Suboxone. Yeah, they do. It's interesting. I have some thoughts on that, but that's all just opinion and conjecture. I think that's just what people are used to. And we've had clinics that have fed that preference. So.
I've got a question related to something that you had mentioned about the Sublocade and having difficulty identifying appropriate patients for that in your clinic. What are some of the reasons or factors or barriers that you've found in trying to initiate that formulation?
So it is a very highly controlled formulation in that there has to be a very clear chain of command. It is never, ever, ever in your patient's hand. There's a specialty pharmacy from which you procure it. They will deliver it to your office. You have to have a secure means of holding it in your office until you put it in your patient. It should never be in your patient's hands. If you were to inject into a vessel the Sublocade, it makes a gel and it can turn into an embolus. It could be fatal. Which is why we have that chain of command of the medication. And then there's getting the insurance to cover it. I've recently learned it is not on the pharmaceuticals that Medicaid covers in Tennessee, but it's covered under the medicine part, not medicine. I don't even know how to make sense of it. So your medical coverage with TennCare covers Sublocade, but not the pharmaceutical coverage. So I haven't figured that out yet. You also have to have staff who's trained. Specifically, it's a sub-Q injection, but you have to go through training of how to sub-Q inject your Sublocade. So you have to have trained personnel in order to inject it. So those are some of the barriers, just navigating what the system is. With TennCare covering it under their medical portion, we should have it covered and cost shouldn't be an issue, but there are coverage support plans that you can engage with through the Individor company, the people who make it. And yes, Individor has been involved in a lawsuit around how they've marketed some of their products and maybe misled us on how great they are, like the Suboxone with its abuse deterring naloxone in it. But anyway, they're useful medications, lawsuits aside.
I think there was another question about the effect of the buprenorphine on neonatal abstinencing.
Yep, I'm just saying that now. There is. Yes, actually, there is a difference with buprenorphine in the setting of neonatal opioid withdrawal syndrome. So if you think about it as a spectrum, methadone, heroin, buprenorphine, you have lower incidence and less severity of neonatal opioid withdrawal syndrome with buprenorphine. You see more, you're more likely to see it, and you're more likely to see severe withdrawal syndrome in kiddos whose mamas took methadone than you do with heroin or oxycodone. But you see less incidence and less severity with buprenorphine. However, that isn't to say it's a guarantee. You could have a mother who's maintained on methadone and she's breastfeeding her child, and we don't have to go to the NICU and we don't have to use morphine. A lot of what we see, I'll be very honest and transparent, this is opinion backed by evidence, of what we see with withdrawal syndrome in our neonates is iatrogenic. So we put them in a high stimulus environment, such as a NICU. It's a busy place. There are people moving about. There are lots of isolates everywhere. People coming and going all hours of the day and night. They're in an isolate or a bassinet. They're not being held by a mother. They're not rooming in. Breastfeeding actually is one of the most positively correlated interventions you can provide to reduce the severity and incidence of withdrawal syndrome in these children. Rooming in also makes a big difference. So not going to the NICU, which our hospital, they do room in and they monitor for 5 days. But we also will see occurrences of babies being evaluated and scored on the withdrawal scale, being woken up abruptly, overhead lights being turned on, the child being hungry when they do the scoring. All those things can artificially inflate the scoring. So some of the things we see with withdrawal syndrome scales can be artificially inflated because of the way in which we're approaching that infant. But buprenorphine, when you look at it just from the standpoint of if I have a mama on this medication, that medication, or that medication, you're going to see less severity and incidence of withdrawal syndrome on for those kiddos whose mamas took buprenorphine. And interestingly enough, it does not matter what the dose of buprenorphine is. You could have a mama taking 2 milligrams or 24 milligrams. That does not change the incidence or severity of the withdrawal syndrome that neonate is going to experience. Questioned you all out.
Yeah, well, thank you so much again, Dr. Troxler. This was an excellent presentation.
Good. I'm glad you guys enjoyed it. I hope that I gave you something that was useful. So thank you. Bye, everyone.